So fire when ready.
Okay, so we are Team 8. My name is Lakin. I'm a student physical therapist.
I'm Daphne. I'm a master's in nursing program.
I'm Dave. I am a student dentist at Rosedale.
And I'm Morgan. I'm a master's social work student.
So we're sharing with you our thoughts about this case, and we hope you enjoy. So meet Dorothy. This is our patient. She is a 77-year-old African-American female. She lives here in St. Louis with her son and granddaughter. Her granddaughter brought her to the emergency department because she noticed she was having some slurred speech, wasn't able to get out of her chair. Since Dorothy has a history of stroke in her past, her granddaughter was pretty concerned, so brought her in. With the workup, they found that there was no CBA, but we have other concerns as her healthcare team.
So on investigating what was going on in Dorothy's life, we came up with several things that we need to address. She was dehydrated, and we did some labs on her and noticed that and looking at her BMI, which is 19, that she's malnourished. She has anemia. We suspect it possibly could be due to the malnourishment. She's got some polypharmacy going on and some adverse drug reactions going on between some of that polypharmacy. There's a poor management of diabetes. Her A1C is 9%. She has a purulent wound on her left lower limb and signs of impaired vascular. We don't have any pedal pulses that we can feel in her feet. And she talks about the fact that she has vascular problems. So she's definitely got some big vascular problems in her peripheral system. She's got some uncontrolled pain that's not being addressed in the hospital. We need to make sure we're taking care of that. She has mobility limitations that makes her a fall risk. Ooh, oh, that happened, sorry. I pushed the wrong button. Sorry. Went back, there we go. She's got some visual problems that we would like to take care of and address. She needs her assistance just to perform everyday living issues that she needs help with, which is her son's at home and moved in to take care of for her. She's got some dysphagia. We've noticed some cognitive defects going on, and she needs to be assessed for that. She has depression, anxiety, and since she had her stroke 3 months ago, she's been socially isolated. She has urge incontinence. She has poor oral hygiene, and part of that oral hygiene is she's missing teeth. She has dental caries and thrush going on in her mouth at that time. And because of a lot of things going on, the cognition, the purulent wound, the vascular problems, she's having some problems. She's extremely big fall risk. And her medical history that we have is that she has type 2 diabetes, the urge incontinence, the stroke that she had 3 months ago, depression, anxiety, chronic kidney disease, hypertension, and osteoporosis.
I'll mess it up, I promise you. I promise you. Okay, so some concerns about Dorothy is that she is presenting with signs of physical abuse and neglect. And as medical professionals, we do are mandated reporters and have an obligation to report that. So move to the next slide. So some of the signs we did see were circular bruises around her wrist, bruises on her legs. So she does live with her son, and her son was at the hospital with her, and just the interactions between them, the son was definitely concerned about the money being spent in the hospital, and she was very worried about pleasing her son, and just the interaction between them was a bit fearful at times. She did come to the hospital smelling of urine and appeared very unkept, so poor hygiene. The malnourishment and the dehydration were also issues, and then the open wounds that were not addressed. So due to all these signs, these are things that we would hotline for. So one of the things I wanted to talk about too was not only are they going to come in and investigate, but they will also offer resources, help with the caregiver stress, because just some background about the son is that he did just lose his job. He's now working part-time. He's taking care of his mom. He also has another daughter, the granddaughter that brought her in. So there's just a lot of caregiver stress. So I really think hotlining would not even just help with the investigation, addressing the abuse and neglect, self-neglect, but also providing resources, particularly caregiver stress and case management. So we wanted to also talk about ethics in this case, particularly self-determination or patient autonomy, because the big issue is going to be with Dorothy's discharge plan because of the abuse, and just being sure that we're being respectful of her right to make her own decisions. So I did put in here about the fact that she is a competent person at this time, and she has the right to make unhealthy decisions. So until two doctors deem her incompetent, she has that right until it can be given to a power of attorney or a guardian, which it did not mention that she had a power of attorney in this case. We also put in here about cultural considerations because she is African American living in North County. We did think that that was something that needed to be addressed just because of mistrust of medical staff due to previous studies that have been done. The Tuskegee that was done previously, there is some mistrust in that culture. Also, with her age and the Great Depression and views of money, it's very hard for geriatrics to let go of that, let go of their stuff. And then just a strong kinship.
So keeping all those concerns, considerations in mind, we come up with our goals for Dorothy. First and foremost, keeping patient number one. Her goal is to go home. She wants to go home and to be as independent as she can within her home. The family kind of seconds that and says, I want her to come home too, but we want her to come home ASAP because they're really concerned about finances and keeping medical spending down. Kind of moving into our thoughts as we read the case, we want to create a positioning schedule with her, skin checks, that way we can totally minimize risk of pressure ulcers or any other kind of bed rest issues. We don't want her leaving with more issues than she came in with. Part of what Daphne talked about was polypharmacy. We want to look at her medication list and see what can we modify, what can we change, what can we look at to really minimize adverse reactions. We also want to focus on her malnourishment and dehydration so that she's healthy, keeping in consideration her diabetes, dysphagia, and other medical conditions she has going on. We want her to be independent. We're kind of seconding that as well with Dorothy. Want her to be able to be mobile within her home, being able to do independent of daily living tasks. We want to reduce her risk of falls. We want to look at her wound. We also want to maybe initiate, maybe not fully, so probably bump into outpatient as well, but maybe get some bladder retraining. As physical therapy, we can look at some pelvic floor exercises, maybe helping her with that incontinence. We want her to really utilize resources, not only to be engaged in social activities, since she's experiencing isolation at this time, but really using resources to get her proper medical care as well. We want to determine the cause of her cognitive impairments. That could be due to the polypharmacy, it could be due to her dehydration and electrolyte imbalance issues. Also, could be a new onset of dementia, so we kind of want to look at that and see what we can do for her. Other goal is to really think about where we want to refer to after she's done with us at the hospital. Who is she appropriate to see, and keeping in mind the finances and transportation issues that come along with that.
So as you can imagine, after we've briefed you on Dorothy's many health and psychological conditions that she has, she's going to have quite a team of healthcare professionals that are going to be working with her and her family to improve her health status. And you can see many here that are going to be working very directly with her, and even some outpatient sources like podiatry, ophthalmology, dentistry, that we'll try to get her in contact with so that she can improve her oral health. However, again, it's not just this team that's working independently of each other. They have to work, again, as a team. They have to coordinate their efforts to really begin to focus. And so using a key driver diagram, go ahead and go to the next one, based on what we have initially seen in Dorothy, we have some things that we're concerned about, and we'd like to get them addressed as quickly as possible, utilizing the team that would have expertise in these fields. As you can see, with her visit to the hospital, the medical doctor and the registered nurse are going to have a great deal of interaction with her. She and her granddaughter and her son will be interacting with that nurse and with that doctor, coordinating and discussing these health concerns that she's experiencing. And then along the way, including all the rest of these specialists that can work with her in improving her overall and psychological health. Again, the question is how do we get all of the healthcare professionals to take care of Dorothy? She's one person, they are many, and they have many responsibilities on their table, as we all do in our professions. It's really hard to get everyone together on the same page to have a unified healthcare plan for the patient. So our idea was, while she is in in-house care, we'd be able to do bedside rounding with her and her family, having her family members present, having a team of healthcare professionals visiting her, discussing things with her and her son, and educating them, speaking with them about how they can improve on her health conditions, and how they can improve, especially the son, how he can improve as a caretaker of his mother. I'm sure he has a great deal of stress on him, being the only source of income in the family, and having to take care of her and take care of his daughter. He's got a lot on his plate, and he needs help. And so part of our team is not just to address Dorothy, his mother, but also to address him and his concerns, because overall, if we can help him, she's going to be better off as well. So we believe that bedside rounding is going to do great. Also, being able to assign follow-up care after she's out of the hospital setting, giving that follow-up and continuity of care that she can receive, and also he can receive as well. So he has lots of resources to help his mother. Those things we believe will help unify our healthcare team to improve her health.
So some of my interventions as the social worker would be to discuss discharge planning with Dorothy and which way she wanted to go. At this time, we would be recommending a skilled nursing facility. So I would be talking to her about that, especially because she does have, religion is a part of her culture. She was very active in her church before her stroke. So something I could talk to her about is a religious-based organization that would help meet her cultural needs as well. And if Dorothy declined the facility discharge, I would work with her to refer her and her caretaker to different resources in the community. I put a couple of examples here, especially call ride transportation would be really helpful for her, especially with all the outpatient appointments. Meals on Wheels to kind of take the stress off of cooking, off of the son, to kind of help with that caregiver stress. Catholic charities, there's also Lutheran Senior Services that could help, just depending on where her faith or spirituality lies. And then area of aging to discuss Medicaid and chore workers. Another thing I would talk to her about in the hospital is advanced directives. It's really imperative that she have some kind of plan for the future, and then also information about power of attorney. I would discuss this, but I would not have her go through the paperwork just because of the hotline that would be open at the time, but it's always good to have the information.
All right, so for the doctor, he's got a lot, or she's got a lot to do. They'd be doing the head-to-toe assessment of Dorothy, doing the diagnosis with that head-to-toe, reviewing her medical history, managing and reviewing her scripts, her prescriptions, ordering new scripts, evaluations, labs, monitoring the labs, and monitoring the evaluations. What we mean by evaluations, like having nutritionists come in and see what kind of diet we're recommending for her, and OT and PT, and seeing what's going on with her and what their evaluations are saying about her condition. Referrals, those referrals that we talked about to nephrologist and neurologist, an endocrinologist, and they would be, of course, doing some patient education. For neurologists, we would assume that they would meet the neurologist in the ER because she brought her in for a stroke, thinking she was having another stroke. But also, you know, like I said, we're not quite sure what's causing that mental cognition and if there's some dementia going on. She's lost her sense of smell, and that also concerns us neurologically, as well as neuropathy, because when she came in, no one mentioned the fact that she had a pain of an open wound on her leg. Nobody said anything. That was not the reason they brought her in. So, and she has no pedal pulse and she's having problems walking, so just a good evaluation to see if she's got any neuropathy coming in. As a nurse, there would be a lot to do. So I'd also be doing assessments, a different type of assessments every 4 to 2 hours, depending on what the doctor ordered. We'd have a wound care nurse come in and do an assessment on what needed to be done with that as well, as methylex or how we're going to do a 2x4. And so I'd be doing the following up care with that wound care that's ever been prescribed in the system. You know, I'd be doing hanging the meds, holding the meds, calling the doctor. For example, she went into the hospital and she's on 3 blood pressure medications, one which happens to be a diuretic, and her blood pressure is very well controlled and she's dehydrated. So I would call the doctor and hold that med and say, hey, she's on a diuretic and she's dehydrated. Would you like me to hold this drug or prescribe something else, or, you know, have another look at that, as well as the fact that she's on a benzo and she's having these cognitive problems and a tricyclet and just there's a couple drugs in there we want. And I'd be calling over the fact that her blood's not being tested. She's malnourished and we don't know what her blood level is. We know that her A1C is out and we're giving her insulin, well not insulin, but metformin and glyphosate, but we don't even know what her levels are at. So these are things I'd be calling a lot of things to the doctor about. With PT, I'd be helping her with ambulation, getting to the bathroom. With her dehydration and malnutrition, there might be intake and output monitoring done, so I'd be keeping that monitoring. I'd be any open lab orders that the doctor wants done, because she's not very mobile and in the hospital for a while. There's possible that they may give her a heparin shot, so I'm going to be having those labs open in order and keeping on track of her PT and making sure that if there's any abnormal labs, I'm contacting the doctor. Monitoring vitals, making sure she's getting oral hygiene and teaching her about that. Bedside handoff with nurses, making sure that I always use SBAR communication when I'm talking with the doctor so we can get things done very effectively and very quickly. And coordinating care, and that means when we have other people coming in, she's got a lot of team members coming in and making sure that one's not overlapping the other. And that we have a good schedule for her and that we're not also tiring her out. Turn schedule, making sure she's getting turned and we're checking her skin. Toileting, because she does have the incontinence and we want that will start with that bladder retraining and getting her to the bathroom every hour or every 2 hours to just see if she could go. Fall precautions, making sure she's on fall precautions, her bed's low, her rails are up when she's in bed, she can always reach her call light. Contacting team members such as the social worker when we have the signs of abuse, and the doctor. Therapeutic communication for when she talks about being depressed. Education on so much. It's 20 minutes. We don't have time for all the education we go through. And of course, discharge planning, especially if she's going to go home. We're going to have a lot of education and planning we're going to need if she decides that she doesn't want to go to the skilled facility.
With rehab interventions, overarching goal with all of us, I think, would be increasing her independence while keeping her safe. That go through a lot of hands-on care, but a lot of patient education, making sure she's aware of everything that's in her home, rugs, pets, any obstacles, shuffling her feet, that we can make sure that she's safe when she does choose to go home. PT specifically, we'd be working on her mobility, able to get in and out of the chair, in and out of the car if need be, gait training, strengthening balance to help with all the mobility issues. We can start that pelvic floor strengthening program. That would probably be thrown out to outpatient though as well. Working with nursing on a positioning program, making sure she's getting pressure relief, and educating her about pressure relief, how it's important not to stay in one stuck position all the time. And also we can work on wound care as well, whether that's us, the primary, or we're working with someone else. We can do that. OT, focusing more on those tasks of toileting, bathing, dressing, making sure that she knows how to adapt. I guess her techniques, giving her adaptive equipment that she can use to better do those tasks if she does go home. And then making recommendations that are realistic. Her family's very concerned about money, so making sure that we're giving her appropriate recommendations. Like a chairlift may not be most realistic in this case, but maybe a shower benches. So working with Dorothy and her family on that. Both OT and speech can work on cognitive issues. So giving her some of those brain training tasks. Speech would also focus on swallowing. She does have dysphagia, and she can easily work with the nutritionist to figure out the perfect meal plan for her, especially with the malnutrition. Nutritionists might be like, yeah, let's get her a steak. She needs it. She needs the protein, but speech is like, no, she'll choke to death. So they need the perfect balance to come up with a great plan. So leading into that, even more interventions for Dorothy, bringing in that nutritionist because of the malnutrition, coming up with a good meal plan for her, and a lot of patient education about counting calories, monitoring her glucose, teaching both the patient and her family why these are important. Help with the pharmacist. There'd be a lot of collaboration between the pharmacist and the doctor, streamlining that medication list so we don't get any of those bad drug interactions. Along with this, something that Daphne brought up, Missouri is the only, 2 minutes, thank you, only state that does not have a prescribed medication like monitoring program. So maybe pharmacists, maybe not specific to Dorothy, but for all patients, can contact our legislators and say, hey, like, let's get on this. Bringing in psych and clergy for counseling purposes as well.
Many of the other outpatient referrals that we're going to give, ultimately we kind of have a question, how is she going to be able to afford it? How will she be able to get there? So lining her up through the social worker, giving her those resources of the community, public transportation, other services that will help her to get there and to pay for these, because that is a big concern for her and her family. Many of the other outpatient services are directly related to some of her health conditions, and so keeping them in the loop and addressing those health concerns. My expertise as a dentist, go ahead and go to the next one. As a dentist, we're able to see some of the first signs of disease, and a lot of people don't realize that. We can see so much disease through the mouth. And unfortunately, Dorothy's part of a generation that has a different philosophy about dentistry. If it hurts, you pull it. You don't go into the dentist until it hurts. And so part of my job is to be able to address some of those pathologies that she might be experiencing. She may actually need a specialist, a dentist specialist, to help her improve some of her functionality of her teeth. And of course, staying in contact with the physicians. If she needs major surgery, I need to know that she's diabetically under control. Staying up to date with her pharmaceuticals. These are all things that I need to take care of as a dentist. And of course, the oral hygiene instruction. Being a geriatric patient, maybe not having as much mobility in her hand to do oral care. Those are right up my alley to help her address that.
So you're kind of over your 20 minutes.
Yep.
How many more slides do you have?
This is the last one.
Oh, okay. Go for it.
Finish it.
So just for Michael talking about more caregiver support groups, resources given to the family such as CPR, and then definitely a case manager to be able to juggle all of things going on with her.
Questions? Judges? Questions? Comments?
I have lots of questions like this. I have 2 questions. So you recommended a sniff for her. Would that be a temporary or a permanent recommendation?
That would just be temporary for a post-acute unit to kind of deal with the wound care, just kind of depending on where that's at, and also to work more on the therapy.
Our idea was the fact that she's got a lot going on, and that we could get her hooked up with like Medicaid on top of her Medicare services. We could put her there temporarily to build her strength up. She wants to be more independent, And we want to be able to make her more independent. And if we can streamline all those services there and get her daily therapy, that's going to make her go home.
I was thinking she owns a house, so that would work probably.
Well, Medicare would probably pay for a little while.
Medicare would pay for the
Yeah.
SNF, but Medicaid would not be
Yeah.
a doable thing because she has a house.
Yeah, she may not be eligible for Medicaid at this point.
Right.
I have one more question, following up from that. So you mentioned, obviously I'm a physical therapist and physical therapist, so you talked about mobility, obviously, and the things that you do mobility. You talked about bladder control, which was, some things out of the box that we think about, and talked about wound care, which we can do as well. One thing that I was curious about was the positioning schedule. Because for me, I'm curious as to what warranted you to that. I think as a physical therapist that we try to encourage mobility and movement as opposed to turning schedule. And I think when we put somebody on a turning schedule, those are more people who are bedridden. So I'm curious as to the thoughts as to, you talked about both. So how they coincide.
Within the hospital, I can speak to the nursing part and the turning schedule. And the fact that in the case study, she's not mobile. She can barely walk to the hospital, to the bathroom.
Yeah.
She can't walk without assistance at all. And when she gets up, she doesn't want to walk. She's in pain, she explained, and then when I talked about the uncontrolled pain, it's only when she gets up and stands on her legs. She says she has a 5 out of a scale of 0 to 10, and she's not wanting to walk. So she's not being mobile at the time. So for the hospital, she is going to be in the bed. She's going to be hooked up to an IV, obviously with the malnutrition and with the, especially the dehydration. So it's going to be dangerous for her to move anyway. She's a fall precautions. For her to get out of bed, she's got to let us know, and we're going to, let her know, hey, if you got to get out, call us, we'll come get you, we'll take you to the bathroom, we'll help you out, whatever. But she's not walking, so she needs to be turning if she's not turning herself.
Correct, and I guess my question is in looking at physical, and again, it's just kind of my philosophy of things, in turning her, I guess for me, I look at it as she is walking with therapy, she does use Minister, she refuses to use a wheel walker, she does have pain, but the encouragement for me would be self-movement, because she's able to get to the edge bed by herself, or sitting versus laying down schedule, and maybe it's worded different for me to understand true turning schedule would be more of something that would be somebody who can't turn themselves or somebody who is unable. And I understand 5 out of 10 pain, but 5 out of 10 pain as a therapist doesn't impede me from getting them up and making them walk. So
I know as a nurse that when we address that tells us, hey, let's look at what the doctor's ordered on pain, because a lot of times they'll put in there like pain 5 to da-da-da, or 2 to 3, give them 5 milligrams of oxycodone. But on top of it, for us in nursing sometimes is making sure that they've moved, because sometimes you go in there and you see in the last 3 times you've been in there, and you, either for that patient bed or another, that they haven't moved, they've stayed in the same spot. So even turning is saying, hey, we need, can you roll over your side? You've been on your back a little bit, and you can even do things like, hey, I want to check your backside, because you do need to do those skin checks, and looking back there, and the fact that she's got a BMI of 19, so she's got bones on bones if she's laying there too long. And we didn't know, we didn't have the MD, but if she'd be on sequentials even, because she's got that wound on the leg. So we actually didn't address that because we didn't know the answer to it without a doctor.
It's an incomplete.
But it was an incomplete, and it wasn't in the case study. But for me, as a nurse, I want to make sure that she is moving. So turning on top of it is looking at, have you moved?
And I'm not saying you shouldn't at all. I guess I would rather see it be either a walking program or up in chair program as opposed to a positioning program.
Well, and she's probably changing quickly. If she came in really dehydrated, by a few days, she probably would look a lot different, Yeah.
So that was I was just curious your reasoning, and thank you.
Okay, no problem.
So I had a question for you. So, I think it was really good that you caught the potential abuse here, both neglect, either self-neglect or family neglect, plus potential abuse with the bruising. How would that impact your discharge planning?
We had a lot of, I would say team tension maybe, I don't, obviously resolved, very healthy team tension. But I think having that safety concern, like I don't want her to go home just to go back to another bad situation. So I think that's why we were really pushing the SNF, skilled nursing facility, but kind of like we're
And
gonna
it's
address
just a
is.
self-determination.
it's
I mean, if they're still
ultimately-
saying she's confident, can make this decision, I mean, we can hotline and then I would feel like it's kind of the state. I mean, can't make her stay.
Her slum
Can't
score
make
is
her-
not that bad, you know, 23
I'm
out of 30,
sorry.
her slum score, her mental status,
It's
so
not
she
like
would
she's
be,
incompetent.
she would probably be competent, as long as she can understand the consequences of her actions.
Well, I know, we didn't give too much detail, but we conceived that, you know, she owns the house, the son and granddaughter are living there, she can't really sell the house, where are they gonna go? It would be a very
I didn't
sticky
know how.
wicket to try to resolve that, so
How
I
that
think.
worked with the Medicaid, because isn't it with spouses, that the spouse can stay in the house and the house
But
is
there's no
accounted for?
spouse.
But with the son, I wasn't
Well,
sure
it also
how
depends on
different
the
that
value of
was.
the house and
Yeah.
all those things too. And
Yeah.
I know also in the hospital, or at least from my experience, when there's been a suspected abuse and someone's been hotline, but, you know, there's an investigation, there's no proven, that we kind of put in a note, when this person comes in, keep an eye on it to
Right.
make sure. And so there's kind of like, you gotta leave the door open, you can't shut the door, and if they start yelling or say anything, then we kick them out. But there's there's literally a red flag in Epic that says, red flag, look at this, hey, this person has a special need with a possible abuse, so, and they'll tell you who, so you keep an eye out for that.
But there's
person.
enough to hotline her, I mean, I think that was right, and then someone will follow up, you may not get to from the hospital, but
Right.
someone will
We
follow up.
definitely talked about when to hotline too, and we definitely felt like this was something to do in the hospital, especially if she didn't, you know, decide not to go, but because there is sometimes some issues with, you know, hospital discharge or skilled nursing facilities, sometimes there's miscommunications.
yeah, it's also good to talk to the family members about, oh, how did this happen? You know, we noticed, you know, get each family member's, you know, report too.
One thing I was telling them is something that actually I learned last semester, 2 semesters ago in class, is when you do suspect abuse, and what she has, it says in the case study, he's talking over her, he's not letting her answer, you know, and he's taking over her care. And when you have a situation like that, you can get those answers by saying, you know what, I gotta take her in for an x-ray, but we can't have you in the x-ray room, you know, and then you can separate them, wheel them in there, and even if you don't actually get an x-ray, you can have that time to get away. But different techniques on how to separate, so you can ask those questions, because of course, when that abuser's there, you're certainly not going to ask those questions in front of someone that you
Right.
suspect is doing that. So there's definitely ways we need to also separate the fact that when he's there, because he was in the hospital talking over her and not letting her answer.
Great. Well, we have to end this.
Yeah, we have to go,
We're
real
over
quick,
time.
you got a quick.
Okay, so with the group rounding, would the family members be present for that, or would that be something that you would just recommend doing with the patient?
I think I would talk to the patient about what she wanted to do, really, just because, I mean, if she seems to have a really good relationship with her granddaughter, it's more the fact with the son, so, you know, I mean, I think I personally, as a social worker, would leave it up to the patient. It's kind of my go-to.
And I think, you know, especially with the nurse, we spend so much time with the patient that over conversations, we could read that. Because I would let her know, hey, you know, I'd start that education in there.
Yeah, we have to move
We're in
on.
the other
Sorry,
team's time now.
We're on a tight time frame, but very good, thank you.
Nice job.
Nice job. Thank you so much. And you would send the
Want
next
us to
group,
live-
just leave it right there?
To
Don't
leave
touch
that
it, yeah, don't touch
presentation.
it.
Don't touch it, please.
Yeah, don't do anything else, don't do anything else.
You're good.
Just
Are
walk
we
away.
recording?
Absolutely, yeah, thank you.
Thank you very much.
Good to see you.
So that was team 8, now we have team 11.
Yep. Hi.
Welcome. While you're setting up, we'll introduce ourselves. Let's start.
I'm Dr. Angela Sanford with Geriatrics.
Hi, I'm Jill Fitzgerald from Physical Therapy.
Yolanda Evans, speech pathology.
Pam Huggins, social work.
And Lance Nursing, welcome.
Sorry.
You have a second to find your stuff.
Um,
No problem.
Is it down at the bottom there, which is view?
All right, and you want me to download this onto the desktop, correct?
Please, yeah.
Okay.
Mhm, yeah.
Cool. And I'll just name that group 11.
Your names are on it, we figured it out.
Okay. Great. All right, well, thank you guys for this opportunity. We're Group 11. This is our presentation for our recommendations for interdisciplinary care for Ms. Johnson. My name's Katie Kanak, and I am from the Speech Language Pathology Master's Program.
My name is Francesca Vaca. I'm a medical student.
I'm Kate Brown. I'm in the Accelerated Masters of Nursing program.
And I'm Megan McDarby. I'm a clinical geropsychology student.
Let's get started.
Great team. Next.
Here are our goals and objectives for our presentation to center around Ms. Johnson's care. We'll go through these one by one through the presentation.
So we just wanted to start out with a quote, which we unfortunately don't have time to read to you, but you can read on your own later. But it really just does a good job of describing the interdisciplinary primary care model as a whole and why it's really relevant. And something that is really important to point out is that the interdisciplinary care model has significant impacts on both patient outcomes and the healthcare system in general. So empirical evidence has actually demonstrated time and again that the interdisciplinary primary care model can decrease costs associated with the healthcare system. It can decrease utilization of the healthcare system, which would include hospitalizations. It can increase the psychological outcomes of patients. It can also increase patient survival rates and increase adherence to medication. So just by employing this model today, we are demonstrating that we really want the best for our patient and that we might have the tools that we can use to succeed in treating Ms. Johnson.
So as you can see, we have a very complex interdisciplinary care team for Ms. Johnson. So this involves her primary care physician who's responsible for medication regimen, labs, referrals. We have her endocrinologist since Ms. Johnson has diabetes and we want to make sure that she's maintaining that regimen and also her diet. As for the neurologist, he comes into play now because there's those new stroke signs versus old stroke signs. We want to make sure we differentiate with that. And then we have our nurses and CNAs who are there for acute care and activities of daily living.
In terms of our team to address Ms. Johnson's socio-emotional and spiritual needs, we're really going to rely on the collaboration between 4 people: the clinical psychologist, the psychiatrist, the chaplain, as well as the social worker. And we hope that the social worker will sort of act as the overall case manager for Ms. Johnson, but the idea is that all 4 individuals will be collaborating. The social worker will be working with the psychologist on assessment, evaluating social isolation, elder abuse, and they ultimately will come up with a care plan for psychology together, and the chaplain will really be there to support Ms. Johnson and her family's spiritual needs and to see how we can integrate that back into the care plan.
For Ms. Johnson's rehabilitative care, we have the speech language pathologist who will evaluate and provide interventions for cognition, dysphagia, and speech therapy. Our physical therapist will do interventions to address right side weakness and overall strength so that she can be able to ambulate herself in the least restrictive environment. Our occupational therapist will work to improve ADLs, or activities of daily living, so that she can function as independently as possible in the least restrictive environment, because this is something very important to Ms. Johnson. And our registered dietitian will serve to provide a well-balanced diet that will both manage her diabetes and be safe for her to consume without worrying about aspiration.
Overall, the success of our patient-centered care depends on the successful collaboration between all the members of this team, and then also Ms. Johnson and her family for the goal of Ms. Johnson's overall well-being.
So we really want to stress quality improvement and safety for Ms. Johnson. This is pulled from 10 Principles of Good Interdisciplinary Work article. So we just go over some main points here that we want to stress. First, we want to identify a leader who has the clear direction and vision for the team. This, in our case, is the social worker. We believe that she acts and listens and also supports and supervises the team. We also want to make sure that we maintain our set of values for Ms. Johnson, which is her family, religion, her social interactions, and maintaining her independence. Next, we want to demonstrate that team culture. We do so by framing our discussions based on her needs and also making sure we round together when possible. Next, we have patient-focused services with documented outcomes. This is very important for us. We want to make sure that we're using evidence-based practice and taking those artifacts and data from the assessments from every interprofessional member. This encourages feedback and captures and records the evidence that we need to help Ms. Johnson improve. Lastly, just effective team staffing and communication. So for this, we have to know Ms. Johnson's strengths and weaknesses, as well as her family's, and we want to make sure that all our decision-making is a collaborative effort. Next, we want to evaluate the evidence.
So since Ms. Johnson is the focal point of our project, we thought we would just summarize a few details about her. She's a 77-year-old African-American woman. She lives at home with her son and granddaughter, and she came into the hospital because her granddaughter noticed stroke-like symptoms, and then also in the hospital, the nurses noticed an infected wound on her leg. Our goal is to both treat these and then also improve her overall well-being, and then also to develop a plan for ongoing care in the next 48 hours.
To look at Ms. Johnson more holistically, we did a SWOT analysis, so we will start with her strengths. One strength that Ms. Johnson has is her strong set of beliefs and values. We believe that this has a lot of value as she has developed an internal framework of things that are important to her, so they will be something for her to ground her and hold on to when times get tough. Another one is her important family values. While they may seem one-sided at times, we believe that this is so valuable that she cares so deeply about her son and granddaughter because it gives her a reason for living and something happy to think about in life. Our last strength listed is her desire to get better. We hope that we love that she has an initiative to be as independent as possible, and we hope that this will carry over into interventions so that she maintains confidence and hard work when things may seem very difficult.
Her weaknesses are the internal aspects of her condition that can challenge her health and well-being. The main points of these are her poorly controlled diabetes, her kidney disease from that diabetes, her poor cognition, lack of independence and autonomy, and then her poor wound healing and peripheral neuropathy.
We've also identified a couple of threats to the care of Ms. Johnson, which are really important to address right off the bat. One major threat is her financial situation. It's possible that her family is just not prepared to take the next steps that might include getting her into some sort of long-term care. So we want to approach that a little bit gently with the family. Along with that, we identify health literacy as a potential threat to Ms. Johnson's care because we don't really know what the health literacy background is of her family, so we want to make sure that when we present ideas and recommendations, we do so in a way that is inclusive of any health literacy level. Another problem is the potential lack of family support. It's a little unclear. Someone else on the team mentioned that we're not sure if it's a one-sided relationship, how inclusive her family is of her and of her care, so we want to take that seriously. And also we're concerned that her family might not support our #1 final recommendation for care, which kind of ties into the first point. So we want to make sure that we consider that as we're coming together and preparing to have this discussion with her family.
So lastly, we'll end with opportunities for Ms. Johnson. So we have the opportunity to increase her autonomy. She's mentioned many times that she doesn't want to be a bother to others, and we have options for her that will allow this. Also, new placement, we will go into in a little bit. And we have opportunities for interventions that will provide improvement in her medical, psychological, and social needs.
So the findings from the lab, nursing, and physicians revealed a lot of the weaknesses I mentioned earlier. And the main ways to intervene in this case would be to first treat her infection, and then also after that to go and manage her diabetes better, and also to manage her nutrition better. because a lot of her additional problems like kidney disease, the neuropathy, and poor wound healing are just side effects from the poor management of her diabetes.
In terms of addressing her emotional needs, we did a full psych assessment for depression and anxiety, and we did discover that she does have depression. We also did some questionnaires for social isolation and loneliness and discovered that she really is suffering mentally. So in terms of assessment, or in terms of interventions, we want to rely on cognitive behavioral therapy as well as some group therapy to try to get social interaction going again, and some mindfulness-based treatment therapies that have also been demonstrated to be effective in geriatric populations. The psychologist and social worker probed a little bit deeper into the elder abuse situation and are going to be working with Ms. Johnson very closely to address her concerns and ways that she may have deteriorated because of that situation.
As for rehabilitative care, the speech language pathologist did a further speech evaluation to kind of evaluate her speech, and it did confirm hyperkinetic dysarthria. For dysphagia, the speech language pathologist ordered a modified barium swallow, which confirmed the predicted oropharyngeal dysphagia, and recommendations will follow an intervention. And as for cognition, the SLP did a informal and personalized cognition assessment as well as the MBOCA, and the evaluation confirmed a mild cognitive impairment that may be a result of poor nutrition, dehydration, and over-medication. The physical therapy, occupational therapy, and dietitians and evaluations are listed in the case study, which I'm sure you guys have all read thoroughly, so I won't rephrase those, but we do have interventions to follow.
So next we'd like to talk about improving Ms. Johnson's quality of life.
What we really want to depict in this graphic is just how closely intertwined our groups are and how the interprofessional care of Ms. Johnson is not only a priority, but it really is necessary, and it's really the only way to accomplish this holistic version of her care. So you can see that the people that we just talked about on the previous slide all fall into one of these 4 categories, and Ms. Johnson is at the center of this care.
There's a clicker. I don't know if she sees that.
That's right. They said there's a clicker over
There's
there.
a clicker.
Okay, sorry.
So our next step will be to identify a home for Ms. Johnson, which may or may not be her own home. So Ms. Johnson wants to stay at home. We've discussed this already. She loves her family. She's really close to her granddaughter, and she likes being around her family. But right now we're concerned that this might not be the best option for her. In terms of getting the rehab services that she needs, in terms of getting her health back up to full functioning, we know that she wants to be more autonomous, and we know that she's really concerned about improving her own health. So we think that a priority should be getting her to move out of the home, and we'll discuss this a little bit later. We think, like I said, she really needs help with improving her ADLs and with rehab, so we're going to try to propose a plan that will help her accomplish these goals.
So the first of these options is the least drastic change to her life. She would still be living at home at night, but then in the daytime from 6 a.m. to 6 p.m. she would be able to come to this adult day health center where she would receive limited meals and then the social interaction that she needs. And she would be able to take a shuttle to and from this place, and so she wouldn't have to worry about transportation. And then also it is completely covered by Medicaid.
Next we have Mary Ryder Home, which is an assisted living home in Central West End. The pros for this is recreational and educational activities are provided. There's religious engagement and also medication management and care on site. Ms. Johnson would live here, however, there's the negatives of patient population that she may not fit into because many of these patients are mentally ill, and there's no skilled nursing, which may affect her overall physical health. We still do believe this is an excellent option for Ms. Johnson, though.
And our star option would be skilled nursing, which we listed 3 available facilities on our slide. All of these facilities do accept both Medicare and Medicaid. As you all know, as geriatricians, or geriatric specialists, Medicare will cover the first 20 days of your stay, and then hopefully Medicaid can kick over to cover the rest of their of her stay without needing to purchase one of the Part B and Part A premiums. I'm still having a hard time learning how to adult. So these facilities all have rehab, where we would recommend physical therapy to address the right side weakness and general strength, occupational therapy to increase independence while performing ADLs, and speech-language pathology where we will intervene with her speech therapy, dysphagia doing a modified mechanical soft diet, and a possible free water protocol, as well as nutritional needs, because there will be a nutritionist on staff that can create her meals so she doesn't have to go home and think of them and have her family prepare them for her. They also have nursing and custodial care available. As you can see, the cons are this isn't at home, and this might be not ideal because Dorothy does hold her family close to her. So, for this reason, these places are all in North St. Louis, so they are in close proximities for her granddaughter and son to come visit. And this takes that burden off them if they find it difficult to maintain Dorothy's care at this time.
Next, we want to guide family discussions.
You have 2 minutes.
Oh, 2 minutes? Okay. Ms. Johnson is the center of our care, and for that reason, our goals will be centered around her and what is valuable to her. Her ability to be independent, her ability to communicate with others, and her overall happiness and well-being. With that being said, we cannot make care-oriented interventions without her being the center of the team and being a team member.
Ms. Johnson has expressed worry over money, and she has often talked to her family about how she's worried that her stay in the hospital will be too much money for them. And so we hope that the social worker will be able to guide her family and educate them about finances, and then also get them signed up for any government programs or other senior health programs for assistance.
We want all members of the care team to be involved in this last piece, which is making sure that Ms. Johnson's family is involved in her care to the extent that she desires, and also to help her designate a healthcare proxy or power of attorney for that situation, which probably will arise when she can no longer make her own healthcare decisions. And we recognize that Ms. Johnson's family may be from a population that is generally mistrustful or distrustful of the healthcare system, and we can never ensure how diverse our care team will be. So it's really important for us to have this conversation, again, in a way that addresses potential lacking health literacy, but also addresses diversity and differences in understanding of the healthcare system and the healthcare that could be provided to Ms. Johnson. So we also want to address goals of care and end-of-life care decision-making for Ms. Johnson, because this is a huge piece of the healthcare system that is often neglected. But I think because we have a primary interdisciplinary care team, if we have the social worker, we have the psychologist who are working with the primary care physician and other specialists, we can really make this a priority and make sure that these needs are addressed for Ms. Johnson. So on the left we have the TPOP, which is the same as a PULSE form, which is really like a quick, brief way for Ms. Johnson to outline, does she want a DNR, what does she want to happen if something goes seriously wrong with her medical care. In the middle we have palliative care and hospice questions and answers. This is something that we want to address early so that Ms. Johnson can think about what she wants at the end of life, and her family can also weigh in, like I said before. And over on the right I have an empirically supported conversation piece called Making Your Wishes Known. It's a conversation starter and decision aid to help older adults make decisions about the end of life. And again, in populations like this that may be low income, may not have access, we want to make sure that we're using materials that are tailored to help these specific populations make decisions that are really relevant and important for end of life care.
So lastly, we want to coordinate and maintain future success for Ms. Johnson.
Okay, so as our medical professionals will be responsible for providing data to bring back to team meetings, as we'll explain shortly because we don't have much time left, Ms. Johnson, as our team member, is responsible for providing data for the team as well. So here I have a modified Long-Baker scale, and it will be just laminated and in her room available. And after each intervention, so after taking pills, after a meal, after therapy, after a physician's appointment, whatever, she will be responsible for pointing to one of these faces
to report how she felt about her intervention or how she feels about her well-being. That will be documented in the chart and just as valued as any other piece of data that any of the professionals work in.
So this slide just has two graphics that depict how we will manage Ms. Johnson's long-term stability. The graphic on the left is just an ever-flowing cycle of how we will, like Katie said, continually reassess her using her own data, using our data, take the outcomes and bring them back to team meetings where we collaborate and communicate with one another. And it's just, like we've been saying this whole time, the nature of this case is so interdisciplinary, so we hope that team members will be working together just because they want to and because it makes sense, but this model does ensure that the team will be coming back together.
Just to show more on a time basis, we have weekly meetings with the case manager, Ms. Johnson, and her family, regular communication through the chart or through email. Careful documentation is expected from all health professionals as well as collecting her data. And if found necessary, there will be a meeting called, but if not, there will be quarterly meetings with the team, Ms. Johnson and her family, to reassure that she is getting the most quality interdisciplinary care as possible.
Thank you very much. Questions? So fast. Team members, questions? Did you consider elder abuse to be very prominent in this example? And
Yes. Yeah, that's a great question. So immediately, I'm the psychologist, and I think we all noticed it right away. But it was so prevalent, and when we were reading things about, they thought she had anxiety, they thought she had depression, she was on all these psych meds, my first thought was, is this situational depression, or is this a long-standing issue of depression? So we took the liberty of just assigning diagnoses based on what we found, because we didn't want to deliberate about that. But if I had to guess, I would have guessed that it was situational, and that by moving her into a long-term care facility, that a lot of those problems would dissipate. But that's why we really tried to harp on including the family and having conversations with the family and working with her one-on-one as well to try to uncover if it's a problem that's happening because she's at home.
It was also another, one of the main factors that prompted us to try and move her out of the house as opposed to just a day-only center.
That was a nice alternative.
Adult daycare, something to consider. I know we don't have to consider cost, but adult daycares are about $70 a day. And assisted livings are about $3,000 to $4,000 a month. So.
Right, and that was why we put them up as priority.
Yeah, they're
as
options.
ideas.
Yeah. Who knows? She may have a savings account or something.
Yeah, that nobody knows about.
So how, you have an interesting mix here.
Yeah.
How did that go with your team?
It was really good.
Cool. Yeah. We worked well together. It was interesting learning everybody's perspectives. I think it was interesting to learn what everybody thinks of first. So for me, I'm like, I don't care what the problem is, we need, or what the diagnosis is, we need to treat the problem, because I'm a speech therapist, so we treat the symptoms to make life better. You know, where Francesca really did care about the diagnosis. So I went through like the tests, and I was like, well, what is the root problem causing a lot of this? So it's interesting to see how we're trained to think and how that kind of works, but it was really cool to see once we all got together how we could really make something way more than I could have done on my own or any of us could have done on our own.
If you would add one more person to your team, what disciplines do you think would have been?
Well, Katie talked to a lot, and I think Kate did too, talk to like occupational therapists and physical therapists. So I think it would have been.
So you pull people in.
Yeah,
To get
I think we need a
around,
real
yeah.
perspective.
Yeah, if you could only have one more. Ooh.
Maybe the medical family therapists. I don't know. All of them would have been beneficial. Yeah,
That's a good point.
Yeah, everybody.
It's hard, it's complex, so you need them all, right?
We're starting to advocate for social work because of the abuse
I know.
Right.
suspicion.
I sort of felt like you guys didn't highlight the role of the physician as much. You know, like in the SNF, there was no discussion of what a physician can do for her in skills,
Yeah.
which would be a great opportunity. You'll have a couple weeks to months to manage the diabetes and really get her on a good regimen for home,
Right.
in the medications.
Reduce
cut
the
down.
meds.
Yeah.
Simplify the medicine.
Yes.
Yeah. These are all conversations we had.
Yeah.
Yeah, and we learned about
20 minutes ago, or like 30 minutes ago, how fast 20 minutes goes.
Yeah. Like cut.
Yeah. But I think that's a good point though, and I think we were all thinking of people who are there all the time. But it's interesting that you would think a physician would be the last person who would be neglected, or the last person who wouldn't be thought of for a care team. So that is an interesting point that we sort of
I was
glossed
at
over
SNF
that.
all day today. I've been there 3 days a week, and so it's very near and dear to my heart to cut down all the med lists. And really to see these patients hopefully home, and some of them don't make it home, and they become our long-term care patients there.
Yeah.
But one of the medical benefits we saw to SNF was the fact that she would have all of her meals there, and they'd be at regular intervals, so she would be able to have her insulin at the appropriate time after her meals. And she would also be able to have her meds delivered at the right times, because there's no way of knowing at home with the abuse situation whether she's getting too many meds, not enough meds, what's actually going on. And then
And whether the A1C is because she's not getting her meds, or
Right.
she needs a different regimen.
Right. You've got some interesting slides for
Yeah.
Yeah, I like your charts, they're nice.
Is there any like constructive criticism you have about how we would better incorporate interdisciplinary care or anything?
We need to reflect a little.
Yeah.
You'll
get some comments back.
Feedback back.
I think your model was great, I think.
Yeah.
I like that.
We've all
yeah.
learned it, but to actually see it.
Yeah.
Yeah.
That's what's
very
very
nice
nice.
slides, yeah. Well, thank you, we have to do transition.
Thank you. I know you guys have a lot of work into it.
You must have had a good coach.
Thanks for taking the time to meet us too.
Well, thank you.
Hi.
Good night.
Hope to see you next week.
They both were.
Yeah. Awesome. The clinical psychologist was extremely well spoken.
Yeah.
Her voice was.
No, they were very articulate. They were very articulate.
Yeah.
And using a model, it was a little more organized.
Yeah. It really like her family, though, the caregiving, using the.
Yeah, I just was, of course, I'm a physician, but they really never said a role of a doctor at all.
Yeah.
That was the only part I was kind of, I thought they did a great job, but.
So you noticed like who's on that team too? I was surprised because there was a med student.
There was a med student, I know.
Yeah.
They never mentioned
They're
what she
so
was gonna
early
do.
on,
Yeah.
they
She
don't
doesn't
have much
know.
experience, really.
Because like PT was mentioned, they'll
Oh, thank you.
do exercise or whatever, and so I'm the same way, but I'm like, well, they don't have physical therapy.
Yeah, they don't
appreciate it.
Yeah.
I appreciate they included us.
They did include
Right.
it, yeah. And they did have differential diagnosis, so that, that's the doctor, the classic doctor. Sorry.
We're right up top.
Yeah, I think we only have 4 to do for a couple minutes behind me. You don't get too crazy. We've got only one more, so. But yeah, so you're having trouble time. Challenge.
Yeah, but we don't want to use extra time. We want to.
No, but I mean, if they start a 10 minute late, we don't give them 20 minutes.
So real quickly, we'll introduce ourselves as judges.
I'm Dr. Angela Sanford with Geriatrics.
I'm Jill Fitzgerald in physical therapy.
Ilona Evans, speech pathology. Pam Huggins in social work.
Helen Latch nursing.
So welcome.
we'll give you the 20-minute warning so we can do questions and things.
I'll start by introducing myself. I'm Katie. I'm in physical therapy.
Team 2.
There's a advancer there as well, if you want to use that.
Yeah,
Clicker.
I'm Allison Campbell, I'm social work.
I'm Zach Bartowski, I'm a first-year medical student.
I'm Zikran Chowdhury, I'm a second-year medical student.
I'm Courtney Wilson, I'm accelerated master's in nursing.
Okay, so obviously everyone knows the patient, but we'll do a little bit of background. Mrs. Johnson is a 77-year-old female that came to us with her granddaughter. A little bit about her history. She had a stroke, hypertension, she's diabetic, has osteoporosis, peripheral vascular disease, urinary incontinence. She's presenting today with dehydration and some wounds on her lower extremities. So far, we know her support system is her son, Michael, as well as her granddaughter. They both live with her, and right now she's not having any outside community support this time. A little bit about our team that we decided to use all together with each of us. We also liked to include some occupational therapy to go with physical therapy. We like to work hand in hand sometimes. We also wanted to incorporate a pharmacist, seeing as Mrs. Johnson had a large number of medications. We wanted to talk to a diabetic nurse because diabetes seemed to be a very prominent disease within Mrs. Johnson. We also want to talk to people like a dietitian, speech pathologist. Her overall nutrition level isn't great right now, and we'd like to get those things figured out. We also thought about consulting podiatry based on where her wounds are and if they had any sort of input to help us out with.
So some of our shared goals are infection elimination because she has a high white blood cell count. We want to improve her diabetes management. Her A1C level is greater than 9%. She hasn't been eating well and has been having swallowing problems, so we want to improve her nutrition. We want to educate her so she can better take care of herself for diabetes and her caregivers for diabetes, hypertension, wound management. We want to make sure she's more independent so she can perform her ADLs. We want to improve her quality of life, and we also want to make sure she's able to go back to her community by increasing her participation.
So to kind of establish that everyone works at all these, shared goals, we kind of did a key drivers diagram to look at the key drivers. We really wanted to eradicate the infection, improve diabetes, improve her nutrition, improve activities of daily living and participation in social interactions, and improve safety overall and use health education as that. So we went through, these are the interventions we're going to cover during her stay of care and hopefully help her when she leaves.
For the physician, some of the priorities include diagnostics for disease progression, as well as adjusting her current medications and consulting other specialties such as podiatry and infectious diseases.
From a nursing standpoint and using nursing care partners in the hospital setting, we'd monitor her vital signs, her blood glucose. We decided to put her on insulin therapy while she was in the hospital, so we do ACHS monitoring protocol. Nurses administer the medication. We're going to do fluid replacement because she's dehydrated and she's got a very low blood pressure. And then we'd start with doing education immediately right as soon as she's admitted. For speech pathology and dietary, we need to work on the swallow function exams because she has had a history of a stroke and she has some deficits and some swallowing problems. And then she's not meeting her nutritional needs at this point, so we needed to work on that together.
So from a social work perspective, we need to have a family meeting to establish some family cohesion because those are the key players in her life. So if they are not able to work together to better her overall well-being, she's bound to have more problems and possibly re-hospitalization. And then connecting not only the patient but also her family with community resources that they may need.
From a PT, physical therapy, and occupational therapy standpoint, we'd like to touch more on improving her activities of daily living as well as her participation and safety once she leaves the hospital. So a couple things that we'll be touching on are just going to be transfer training, getting her from laying down to seated in and out of her wheelchair. We want to make sure she's independent with stairs in case she is alone at home. Working on her gait and balance, as well as introducing more assistive devices to her. Right now she's refusing a wheeled walker, but if we can get some sort of training and show her a little bit more independence, we might be able to get her to use some more devices. We'd like to work with OT to come up with any sort of accommodations for her activities of daily living. And as always, we're going to do a lot of strengthening. She's really weak, been in the hospital for a couple days. We'd like to just do a little bit of full body strengthening.
So safety issues that we deal with in the hospital, she's got some medication changes, so we really need to look through those, especially with the pharmacist and the physicians. She's got an infection, so we need to make sure that we're taking care of that, changing out the bandages. She's at a fall risk because of her sedentary life. She's got skin integrity. We do DVT prophylaxis. We were kind of concerned about elder abuse, and that's why we would work with social work and kind of make sure that that's not something that's actually going on and mandate reporting that. She's probably got some non-compliance issues, so education. She needs some nutrition, and then depression and anxiety is something that's big in her life right now, so we really need to work with everyone to fix that.
So some of the innovative care techniques that we're going to use are Geriatric's depression scale, the cognitive assessment from SLU, also the Morse Fall scale, grade and score, weekly interprofessional care meetings to make sure everyone's goals are met, pastoral care to provide her with any religious support she needs. We also want to use the ankle brachial index to figure out if she has for her PAD, peripheral artery disease, and figure out what the progression is since she already has ulcers in her periphery, and see what needs to be done. We also have the Beers criteria that we use as far as figuring out the medications and what's contraindicated for the elderly. We want to make sure she's educated and have the medication reconciliation, and we also want to provide her with community resources for independence and housework.
So while she's an inpatient, we have a lot of things that we want to meet. We're going to cover this a little bit more in the following slides, but basically just doing education, exercise, nutrition, wound dressing and management. If podiatry wants nurses to do that, that's something we will do as well. Diabetes education, fluid replacement, monitoring her labs, doing blood glucose monitoring, consistent carbohydrate diet because of her diabetes, and then prophylactic treatment for DVTs, constipation, and then insulin therapy while she's in the hospital on a sliding scale.
Okay, so from inpatient care, from a physician aspect, again, medication management and adjustment. We also want to consult podiatry and infectious disease for her ulcer. And we also want to monitor her vital stats and monitor her blood glucose levels.
The nurses will help with that by doing the blood glucose monitoring and reporting anything that's outside the normal limits. We're going to have a diabetic teaching nurse come in because they're specialized and have that good education to help her out. Wound dressing changes in management, patient education, and then aid with activities of daily living.
So from social work, we do know that her GD score was 10 out of 15, so certainly further assessment for depression and any possible suicidal ideation she might have. We don't have anything that's present now, but because her score was 10 out of 15, we definitely need to look into further depression. And then just again, really connecting the patient and their family with community resources. She had stated that she used to go to church and be very involved with several friends there. So really looking at supports that could help alleviate some of that depression through the community, whether it's support groups, caregiver support, help with her diabetes management in that sense, and then of course the transportation issue. She does not have her license and is hesitant to ask her family for help in that sense. So.
For physical therapy, kind of all things I've already covered. We're going to do a lot of the transfers, gait, stairs, things like that we can make sure we can send her home or to a skilled nursing facility wherever we decide. she should go. We'd like to get all those things taken care of, make sure she has the proper education for those, as well as our overall goal is making sure she's independent with her activities of daily living. We'd like to consult OT, make sure social work is there, talk with nurses so she gets education on her medication. And then ultimately we want to create a plan for her participation goals. She wants to be active in her community again. She wants to be able to do things on her own. So we're going to find things to create a sense of wellness in that standpoint where she's able to community ambulate on her own, and we'll work with social work as well about transportation and things like that.
So for speech and dietary, they kind of work together because we need to know what's safe for her to swallow, and then dietary needs to come up with a plan to make sure she's getting their nutrition she needs. So we're going to improve the coordination of swallowing within her weakness, monitor her swallow strategies and modify if necessary, provide a diet that's appropriate and tastes good because she does have a sweet tooth, so we really do have to play with that. So providing supplements is something that we thought would be a really good idea because they're sweet, they taste like a shake, and they have extra calories and vitamins. And then working with nursing, we monitor the percent of meals eaten so that we make sure she's actually getting what she needs.
So for patient outcomes, we can really categorize these into three: infection control, chronic illnesses, and emotional health. Speaking for the infection control and chronic illness standpoint, we want Mrs. Johnson to be free from infection and maintain her skin integrity, as well as monitor her blood glucose to prevent future wounds, inspecting her feet daily and eating well-balanced meals that are appropriate for her needs. Coming from a chronic illness standpoint, we want to educate Mrs. Johnson and her family about the appropriate management techniques for her diabetes, and then schedule follow-up appointments to make sure that we're continuing with this ongoing assessment of her chronic illnesses. Also, we want to look at the functional independence with her ADLs and look at the within normal limits for diagnostics, including the A1C for her diabetes.
So with emotional health, we want her to express that she's feeling well emotionally. We hopefully get that GD score down from a 10. And we think fostering more social gatherings, having her feel more connected to her community and her past social ties can help alleviate some of that depression. Some financial independence, but also just a sense of independence in general. She relies on her family a lot, particularly her son, and she often doesn't ask for things that she needs to because she feels that her family is too busy, so maybe gaining some independence will help her with that.
So medication management, currently she's close to about 10 drugs, and coming from the geriatric's point of view, that can obviously increase her adverse drug reactions and events. So we try to see which drugs we can discontinue but still achieve the outcomes we're looking for. So for metformin, which is for her diabetes, we realize it's contraindicated for the renal disease, and there might be compliance issues as well, so that's why her diabetes, H1C levels are so high. We also want to discontinue the hydrochlorothiazide because it's at very high levels, and it might be contributing to her electrolyte imbalances and urinary incontinence. And one of the other reasons is that she's currently on 3 hypertension drugs, including ACE inhibitor and a beta blocker. So right now we're going to try to cut down on one of the hypertension drugs, so her high blood pressure her blood pressure is very low right now. We also want to discontinue the amitriptyline. We want to titrate it down. Because it's also contraindicated using the Beers criteria, alprazolam as well. And we are thinking that for her, these are drugs for her anxiety and depression, and maybe if we can get her back to her social activities, that might help, might alleviate some of her symptoms. Oxybutynin is also contraindicated based on Beers criteria for urinary incontinence, and we are also thinking of changing the calcium supplement, or discontinuing the calcium supplement.
So some things that we're going to add. In the hospital, she's on insulin right now, and we're going to put her on an alpha glucosidase inhibitor to replace the metformin after she's dismissed from the hospital. And then obviously we're going to need a broad spectrum antibiotic to treat her wound. This is going to require a consult from infectious diseases in order to culture and gram stain the wound and figure out what antibiotic is best to treat the infection. While discontinuing the calcium only supplement, we're going to add a calcium and combine with a vitamin D supplement. This will address her low vitamin D levels without adding another pill, which would help with compliance.
And just to reiterate the fact that we aren't putting her on an SSRI because we believe she could be experiencing depression, post-stroke depression, her dementia could be adding to that, as well as her limited social support. So just to reiterate, once we get those back in place, we're confident that some of her depression will alleviate.
So again, improving her diet, we need to make sure she's clear to eat solids or at least some, before she's discharged. Adding the supplements that are high protein, low sugar, and low carbohydrate, like the Glucerna shakes. And then improve quality of life. We're looking into a skilled nursing facility such as Nazareth because it's a religious community. We thought that since it's attached and she could stay there and then have a sense of community and friends around her, another support system, that would also help with her home life. But if she chose not to do that, we want to make sure that she has got community transport to make sure she's still getting out and going to see her friends. And then caregiver support is something else because we thought that maybe if the son was helped a little bit more, he wouldn't feel so stressed and
Particularly with the dementia, there's a lot of support groups out there for caregivers dealing with a family member with dementia, so connecting him with some of those supports in order to alleviate any possible strain that he has between him and his mother.
So another thing that we need to consider, considering her advanced age and condition, we need to look at end-of-life planning. This involves preparing and walking Mrs. Johnson through the preparation of an advance directive, if she has not already done so, and then making sure that the hospital has a copy of that advance directive. More from a financial standpoint, we should also talk to her about preparing a will if she doesn't already have one. And these things should be discussed one-on-one with Mrs. Johnson, considering the possibility of elder abuse. So that's something that should also be considered. And then we have the health education, and this includes diabetes management and nutritional education for both her and her son, which is her primary caretaker. And then looking at a home exercise plan for her and her family. This will include exercises to help treat her difficulty swallowing that resulted from her stroke. And we also need to educate the patient on wound care management.
So these are just some lessons we learned as a group while we were working on this together. Diabetes is such a complex disease and it involves a huge team. You saw our list at the beginning and it's not just us here in this room. Communication was the biggest thing that we found was kind of difficult because we all have extremely busy schedules working, in school, and some of us are GAs and everyone's on clinicals and stuff like that. So really, we found that email sometimes was the best way to get a hold of everybody at the same time. So we had this mass email, we had Google Docs, we had all these things to make sure that we were getting everything, everyone was seeing everything, and then we still got to meet several times to work on the project. Each team member brought their own knowledge, background, and it was really interesting working with two new med students, not trying to say that, but it was just interesting bringing the knowledge that they have and how much they've learned so far, and then working together. Some of us are in a clinical setting and bringing that knowledge with us. And then the family and the patient are part of the team as well. Their opinions really do matter. We do need to have them in the team because if they don't support it, it's not going to happen.
You know, for me and Zach, it's kind of like we're not in the clinics yet, so we feel like we got to learn a lot about how the actual hospital setting is. Like we're just learning the diseases right now, but working with these ladies, like we're able to learn a lot more about the actual implementation of those, of the actual plans and what works versus what doesn't work.
Questions? I think the elder abuse, you identified it briefly as a problem. What did you think, what magnitude of a problem did you think that was, and how sort of would you tackle that issue?
I mentioned that as from a nursing standpoint, we are mandated reporters. I was concerned about it, and that's why I would have reached out to social work immediately. So, because I know that I'm maybe not the most qualified to do that, especially at this time, but I have seen it in the hospital, and we call social work immediately.
Yeah, I mean, the bruises on the wrist, the fact that she couldn't remember, definitely makes it difficult. You know, we can't accuse or assume anything. But then some things we read later on in the case, such as the other son who lives far away sometimes had difficulty reaching her, that the son often made comments like, I do everything for you, so stuff like that. I mean, just asking questions, we of course can't assume. So I think it's, at this moment, would be surface level, and we need to look further into it.
How would you do that?
I mean, I think the best way to do it, from my standpoint, from a social work standpoint, would be talking to the patient privately, interviewing the family. I mean, not asking direct questions, but asking those questions that could lead to further explanations. From my standpoint, that's what I would do.
Would you hotline her?
That's right.
That's the question.
Yeah.
That's the question, right?
I don't know that I would. I mean, I don't know that we can assume that those bruises are in any way.
Or even just looking at some other aspects, like the fact that she's not either getting her medicine or not taking it correctly. I wouldn't see as 9.
And
So
not financially independent.
Neglect.
There's some neglect going on there, it seems like, yeah.
of some sort, whether it's self or, you know,
Yeah.
family's neglecting her. It's hard to say.
Right.
Well-nourished. Yeah. It's a tough call. It's always a hard decision to do that.
I think we probably we under hotline too.
Yeah.
We underutilize it.
Oh, yeah,
It's
afraid
definitely
that-
under hotline.
Yeah.
Yes.
And of course, they don't always follow through as quickly as you would like.
But when you're talking about the community in which they're living in, and the behavior of the people in keeping up with medication, it may not necessarily be that they're neglecting to do it because they don't want to do it. It may be that their lifestyles just aren't such that they keep up with those kinds of things.
Or they can't afford it, or they're not getting.
That's where the education would come in.
Gambling in a
That's
way.
why.
We don't know what's going on.
Yeah, we don't know that right now.
Yeah.
When you guys mentioned Nazareth Living Community as a place, is it I know Nazareth, would you recommend the skilled nursing facility? Would you recommend assisted living? Would you recommend, I'm curious as to what area of care or what area of
I think at
functioning
first she
do you
needs the skilled nursing facility just to make sure she's safe, but I'm sure she can move up as she improves. That way she's not so dependent on them and she gets some of that independence.
From the little activity that she's participating in right now, and the high level of medications and all this wealth of information that we're throwing at her because she has 100 things. I feel like being in skilled nursing facility for a little while, having a regimen that is implemented on her and having someone that's there to
repeating it,
watch it and repeat it with her, I feel like would be beneficial for her.
Anything else?
Thanks.
Thank you.
Nice. Very nice.
Good job.
Interesting ideas.
Yeah. Thank you. And hope to see you next week.
If you see the next team, let them
Come on down.
Team number 6.
So BID is for treatment, so if they have them come through DB.
Interesting.
Okay.
So 11 o'clock would still be twice that.
Yes.
Hi.
Big crowd.
You're not judges. They're observers.
my mother-in-law gave me the next one. Confirmed DVT, which was true, but then when her INR came back, it was like, she was like a surgeon.
Oh, okay, was she taking Coumadin too?
So, no, she was it was not.
She said it was
Oh, yeah. Yeah, sure.
Yeah.
The bridge to something else.
Well, that was my thing, she didn't doing it for like.
So while you're setting up, we can introduce ourselves as judges. I'm Helen Latch from
You know what I
nursing.
mean?
And Pam Huggins from social work.
Yolanda Evans, speech pathological.
Jill Fitzgerald, physical therapy.
I'm Dr. Angela Sanford with Geriatric Medicine.
Okay, great. So we'll give you the 20-minute warning.
Thank you.
You want to talk about these? Is that okay?
Oh, yeah, yeah.
Thank you.
You can start whenever.
Okay, go.
So we're group 6, and just before we start, we just want to thank our faculty advisor back here, Dr. Susan Tapp for social work.
Cheerleader. Thank you.
All right,
She doesn't get to grade you though.
My name is Mitchell Edwards. I'm a first-year medical student.
I'm Kristen Barrick. I'm a third-year physical therapy student.
I'm Nina Curry, I'm a first-year social work student.
And I'm Colin Silva, I'm a first-year nutrition dietetics student.
So today our patient is Mrs. Dorothy Johnson, and she's a 77-year-old African-American female. Her admitting diagnosis was a possible TIA, dehydration, infected leg wound, and we're thinking about discharge in 24 to 48 hours.
So this genogram is to help all health professionals comprehend past family history as well as what family members will be there to help her. So during her inpatient and outpatient stay. So she is, we are working with not just an individual, but a group of people, which is her family, and we want to make sure that everyone is okay with what inpatient and outpatient advice we give her.
So this is just a list of many comorbidities which we're going to be covering in this presentation to some extent. These are going to have implications with one or multiple professions that we'll be dealing with.
When addressing the patient, Ms. Dorothy Johnson, while all of those primary concerns will be those different comorbidities and how we can treat them in the hospital, it's also important to take a look into her environment and all the different things that affect her outside of the hospital and how that's going to play a role in her goals, her family's goals, and also her outcomes, which also we want to highlight that she'd like to return home, increase her independence, home health if affordable, and then also a 24 to 48 hour discharge.
As noted before, Mrs. Johnson is the biggest piece of our puzzle, and in our interaction with them, we want to take into consideration all health professionals that will be there with her family.
This is an overarching goal list for us as professionals altogether. We all have a different role in all of the goals, but our main one that all unites us all is we want to improve Dorothy's quality of life.
All right, so let's get into the details. So looking over her charts and her notes, it's evident that many of the symptoms that she's having are uncontrolled by the drugs that she's on. So this provokes a conversation with her and her family on her adherence to this drug plan, as well as her experience with many of these drugs. Perhaps there are some which cause many difficult side effects which she avoids taking. Also, we know that her memory at times seems to be failing, and so some involvement with her family, perhaps having her son administer her drugs, could be helpful to this extent. Of course, with so many different drugs, we have polypharmacy, we have drug interactions that can come about, and of course, she is likely having a couple of these. So some consultation with general internal medicine or geriatrics, as well as with pharmacy, to reevaluate those dosages and the drugs that she's on, to come up with a drug schedule which optimizes the benefits which arise from them, as well as minimizing the risk of each drug will be helpful. After this, a follow-up appointment can be made just to evaluate if the symptoms that we're treating are being mitigated, as well as if the symptoms which arise from interactions are being minimized. After this, if she does not have a primary care physician, trying to help her find that person to be a source of continuity of care and an advocate through this whole process of aging will be very important. Also, her cholesterol was something which wasn't really mentioned in her notes. So she does have many cardiovascular disease risk factors, including a history of stroke and chronic kidney disease. So doing a cholesterol screening while she's in hospital, looking at her cholesterol and triglycerides, will be helpful to see if we need to prescribe a statin to add to that long list of drugs she has now. This could precipitously decrease her risk of dying from cardiovascular disease.
And some complementary medical nutrition therapy that would be really important for the dietitian is to sit down with Dorothy, Michael, and Talia to see what foods they're preparing for her, how they usually prepare them and where they're buying those foods, and how different things such as the saturated fat content, processed grains, and all of that, we can actually mitigate that through dietary intervention and lower her cholesterol without having to go into too aggressive pharmacotherapy.
Now, it's been noted that she has a wound on her lower left leg. She also has diabetes and peripheral vascular disease. Now, I've had firsthand experience with many of these patients, and they have a very difficult time healing. It can easily be a year. So while she's in hospital, a prescription of an antibiotic will be important, making sure that we're not prescribing a penicillin, which she is allergic to. Also, that wound debridement while she's there and dressing it, just so she can return home after that. While she's there, we can also do some education, have a nurse speak with her and her family about how they can perhaps dress her wounds, and or we could have a home care nurse come in for weekly wound care and just to reassess that wound. See if we need to return to the hospital if it does become worse, or see her PCP to see if we can prescribe a new antibiotic.
And just complementary therapy to that, something that dietary would really like to emphasize is proper glycemic control, really maintaining blood glucose for proper wound healing. Also emphasizing protein intake and hydration that's adequate for her weight status to really help with that while she's in the hospital, but also talking to Talia and Michael about that, making sure that's important when they go home.
Now, her renal function, as we see from her labs, is quite poor at this point. She does have chronic kidney disease, and she perhaps might be in a state of pre-renal failure, which is quite concerning. So at this juncture, I would suggest that we refer her to a nephrologist. This has been correlated with a decreased risk of, early referral is correlated with decreased risk of transplantation and dialysis, which of course are going to be quite debilitating for her. And this person is just going to assess her kidney function and her quality of the drug regimen to see if anything needs to be modified from this juncture.
Right, and pending that consultation, we would just look at the different mineral qualities of her diet and see if maybe we can help with that to help prolong the function of her kidneys.
And physical therapy and occupational therapy can come to the family, as well as Dorothy, and kind of get a little bit of an idea of how incontinence is playing in her life, and discuss if a time void in schedule is something that they are interested in. So for example, setting up time and a period to go with her to the bathroom every 2 hours.
Now, her diabetes, as we can see from her hemoglobin A1C, is uncontrolled at this point. It's quite high. So a consultation with an endocrinologist could certainly be helpful. This person could assess her drug plan as of yet and the lifestyle modifications that might be necessary to achieve that control. That person or her PCP could also discuss with her how to cope with those modifications and bring them about in her life, as well as speaking to her family who might provide some support in making these lifestyle modifications.
Again, physical therapy and occupational therapy can come and talk to the family and kind of find out what any falls or anything that has been happening in the home, and then check her sensation or proprioception of her lower extremities, and talk to her and see if she's getting regular foot checks, and see if she needs to get a referral to the podiatrist. And also doing some education with the family if she is unable to do those foot checks, to see if someone would be willing to do that as well.
And in a social work point of perspective, Mrs. Johnson and her family can be more informed about maintaining a log for blood glucose and burdens of a lifestyle change that may occur. And this way it would be more beneficial for us as healthcare professionals to assess her barriers within and see if she needs to, if she would like to go to a support group or any community assessments that will help her and her family.
And lastly, from a dietary perspective, just sitting down with the entire family and really understanding what she's eating at home and what's her pattern of eating. Because right now she is only on oral hypoglycemic agents, so we want to prevent that insulin therapy by seeing how much carbohydrate is she eating, is it consistent throughout the day, how can we change that, and what resources are available to her. Does she have access to food, and who's preparing all that cooking? And making sure that all those lifestyle changes are manageable with the family, making sure that they're monitoring blood glucose 4 times a day to make sure that's consistent, and then also safe exercise tips. We want to make sure that she's up and moving, so doing it safely.
So, since geriatric abuse is so prevalent in our community, introducing physical and psychological abuse is very important. According to Mrs. Johnson's case, there may be some discomfort at home. For instance, the bruises on her wrist, showing that there may be some physical abuse. So questioning both Michael and Talia will be very beneficial, and also talking to Michael about the emotional abuse that might be going on at home with the yelling will be very beneficial in talking to tell him that he can talk in a more calmer way for both the family setting and Mrs. Johnson herself. So when taking care of female patients, we want to make sure that we focus on radar. So radar is routinely screening female patients, asking direct questions, documenting the findings, assessing patient safety, and responding, reviewing, and referring options. So with Mrs. Johnson herself, we want to make sure that we ask her open-ended and direct questions in order to see if there is any abuse going on at home.
Osteoarthritis is something that not only physical therapists but the whole community can do as well. But we can educate her on the pros and cons of exercise and what bed rest may have an effect on her disease.
Right, and complementary to all that treatment, we want to make sure that she has good bone mineral density and quality through diet, calcium, and vitamin D status. So then looking at chewing and swallowing ability, this is something that both speech therapy and also nutrition and dietetics are going to work on in a collaborative effort to make sure that she's very safe when she's eating and that we're maintaining good weight status. So these are some things, some concerns that were raised in the notes, the things that we want to address. But also something I'd like to point out is that patients, especially geriatric patients, are at 3 times the risk of malnutrition on these altered diets. So really making sure that she's safe, comfortable, but also meeting those nutritional needs. So from a speech therapy intervention, just making sure that all the consistency of her food and her liquid is going to be safe for her to eat, whether that's changing the texture of the food, pureeing it and changing it, and you can see here as well a visual of how that might evolve. And then also looking at the sparse dentition, so maybe possibly referring her to outpatient dentistry to really get some good fitting dentures that are needed. And then from some medical nutrition therapy that would really be complementary to everything that she's doing, we really want to emphasize comfort, but also healing through protein and hydration. So really making sure that she's getting enough of her needs here. This is a possible intervention that we could use, an oral supplementation, which you can see her needs here and all the needs that it's meeting here, the majority of those. So we can focus more on her comfort and making sure that she can eat consistently, but this is something that's really easy to help encourage that weight maintenance.
Physical therapy and occupational therapy will be very interactive with the family and with Miss Dorothy as well. We are thinking about possibly gait training her with a possible assistive device and asking her what her home environment is like and seeing if there's any, if a wheeled walker that would be appropriate or more of a cane. Also transfer training, if she's having difficulties in the home or there, we can help train not only her but the family members as well to help her with that. Fall prevention is definitely key for her and her age. We want to make sure that we can go over the home layout to double check to see if there's any modifications that we can recommend and tell the family things to look out for her as well. This is an example of a schedule that may occur in the hospital. This is just showing how each profession will come and visit her and the duration they will be there and how we will work together to kind of cooperatively work and give her the best care possible.
So as a first discharge plan, we would like both Michael and Talia to kind of work with contacting parishioners or even community members to see if if they could find what Mrs. Johnson would like as her wants, like going to church or even going to her community events.
Home health is an option for nursing, OT, and PT as well as social work, and this will be available to check the wound, do another home screening in the home, also do in-home training for not only her but her family as well if it's needed.
As a second discharge plan, if they cannot find any community members to help Mrs. Johnson, we would like to tell the family and educate them about other plans like in-home care at somewhere like bilingual in-home, which will provide benefits and services for her.
And if something else, just accessing free services, since finances are a concern for Mrs. Johnson. We have very many free clinics in St. Louis, and one that comes off the top of my head for her macular degeneration is the SLU Sight Clinic that we have right in North City. So she can go in and get free glasses after passing her, failing a vision every day. And now these are just a couple of reflections we've had in this whole interprofessional process, and you guys can peruse these as we answer your questions. So any questions?
Questions from judges? I guess I have one, in terms of the potential abuse and neglect presenting, how would that impact your potential discharge plan?
So if there is any abuse and neglect going on at home, we would like to first send Mrs. Johnson into therapy and also focus on maybe a nursing home route, depending on her financial stability. So yeah.
How would you determine that if there was abuse?
We would determine it by talking to Mrs. Johnson, Michael, and Talia.
And we wouldn't jump right to we wouldn't jump to conclusions, absolutely, and we know that her family is certainly a large supportive factor in her life. So if there is any way to mitigate this and prevent in the future, perhaps, we saw the circumferential bruises on her hands, and maybe just being to Michael that, so who knows, maybe he's kind of wringing her hands or something if he's frustrated with her. So bringing up that concern with her with him might be able to mitigate that.
Another way to really reinforce this is where the interprofessional communication is. Discussing with each other what stories are common, if they are the same, and really discussing what the feeling with the family, because I may only talk to the granddaughter, someone else may only talk to the son, and really putting all those stories together and forming a collective decision.
Right, and then what we spoke about before as well is the home health option. That's something that she expressed interest in as well. It's something that we could use, that those healthcare professionals would be visiting the home if we maybe didn't make an intervention right away to help communicate that to our primary care physician and also the healthcare team.
Do you think there's really free home care for her? In-home care?
So if there is like a financial instability, there is a service called Bilingual International, which gives free services like a caregiver, and it's basically based on the state. So it's very Medicaid oriented and works with caregivers, nurses, social workers.
Well, she owns her home, so she probably will not qualify, but that's,
yeah.
That's an issue.
Anybody else? Well, thank you. You had some interesting ideas. Very good.
Thank you.
Thank you.
So we're probably going to rate these teams, so I don't think they should listen.
I hope you enjoyed the presentation. So Juanita was on a team last year, and she was a coach this year, so she came to watch her team.
She's an expert now.
That's right. Next year, judge. All right.
That was fun.
Yeah, interesting, isn't it? Well, they were clearly less experienced as students.
Yeah, that was the
some of
most
them.
naive.
Yeah, I thought.
Three was, I don't know, the third group.
Oh, was more naive?
I mean, they got my lowest score.
Yeah, I expected more out of my last two students, but from a physical therapy perspective.
This last social work student was really naive.
Yeah.
Yeah.
I was like, what?
Yeah.
And the one before too, actually.
Yeah, right.
Those were not our best.
Yeah. Well, but she only knows what she knows, so,
Right.
Do you expect that for her, like her level of education, like she was a first year social work student? I'm just
No,
curious.
she's first year, first semester, so that's okay. This one.
Yes, so that's kind
The
of.
second one, the one in the previous group, I'm not sure where she's at, but yeah, this one's, I think, first semester.
yeah, she's seeing them up, the least knowledgeable.
Yeah,
and
but they also had my colleague Sue Tebb as social work faculty.
Oh, that's true.
So I think
reflecting back, I thought the first two groups were stronger.
Me too,
Yeah, the
exactly.
second.
Yeah, I thought, that second group was really, really engaging. Let's see, they were team number.
Yeah, they had the gal, the marriage
11,
and family
11.
therapy.
Yeah.
Team number 11.
They didn't address the elder abuse, and I thought
Yeah,
that
that's
was.
the
But they
one
did
thing.
not
That's the one
address
thing,
that, and
yeah.
that really bugged me, so.
Yeah. Yeah, that was their weakness, yeah.
That was their.
What do we do
But
with that other
do
bulletin?
we give them credit for the post-discussion? You know, like,
Yeah,
yeah,
yeah.
because they did talk about how they discussed it and their decision on
Yeah.
why they didn't make that a part of the presentation.
Yeah, I thought that
they
was
were the
interesting
most
too. You're like,
cohesive
yeah, that's what
team.
we really thought, but then if we wouldn't have asked, we wouldn't know that's what they really thought.
Yeah.
Yeah.
I liked that they had a model of care, which was really
Yes.
interesting. And then they did the patient satisfaction. I thought
I
that
thought that
was
was
interesting. They were
interesting.
very patient-centered. Yeah, oof.
They were good. The first groups, maybe their slides weren't as good, but their content was strong.
Yeah.
You know, like their slides weren't slick. You know?
Like the second group, yeah.
You know, the slides were lists.
Is that too?
Yeah, it was
The
some,
first group is team 8.
yeah.
So, I don't know, it's between those two. But I think they were pretty cohesive too.
I scored the first team highest.
Yeah, I would agree, overall, they had it, their PowerPoint just wasn't that great.
Yeah.
Yeah.
That's my only thing. And they got more of the, I would say a fault of most of the teams was still sort of not.
Seeing the whole picture?
Not involving, talking first about what does the patient or family want.
Okay.
One group did it the best, which
Well, the second team had the Venn diagram with the patient in the center, and then they had patient values.
yeah, they talked about it. Now, I didn't like their SWOT analysis. I don't think that applies in healthcare.
Yeah.
That's totally.
I don't know where they got that though. I mean, maybe
that's a
one of them learned
management.
that though. I don't know.
Well, no, there's SWOT analysis in healthcare. I mean, they see it in our curriculum too, but I didn't think it lined up with their problems.
Yeah.
Her problems, Dorothy's
Yeah,
problems.
I just didn't think that worked. I don't know. So, do we have any consensus on a ranking?
Well,
to
we
give
don't
it?
have to rank them. I mean, we can just score them and see where they fall out.
Oh, I thought we were supposed
Well,
to.
She said.
She said a winner.
But the ranking won't, the ranking, yeah, I don't know,
So
she
we
said
said-
She
that,
said a winner in every room.
So if we pick
Well, I
the
know,
winner and the scores don't.
but, yeah, I know,
match,
that wasn't clear. I was a little, last year we just looked at the scores and calculated the scores.
You want me to write up the scores up there, what we all said?
Well, but we don't have to agree on all these.
Oh, I thought we were just gonna add our total scores for each group and see who came up with the highest.
Oh.
Because I summarized my scores, as, it says the total score, I summarized for each group.
Yeah, I did not score all mine yet. So I wrote notes down, but I didn't do all my scores yet. I know, so maybe we need to do our scores and then.
We can just add up our scores and that will
Right.
tell us what we think.
I had two teams really close. 1, 8, and 11.
The one group that was interesting brought up policy, I thought that was kind of interesting, beyond the patient, was the whole thing about Missouri having a drug.
Yeah.
I was like, oh, that's interesting.
Yeah.
This policy really isn't, but it was interesting.
I felt most connected to the first group for some reason. You know, like I felt like I understand what they were saying, I understood, even though their presentation wasn't as, maybe it's because it wasn't as formal. I felt like I knew the patient, I felt like, I don't know.
They didn't really present the case though, much, the first group, or the second group. The third and fourth groups were better at sort of presenting, getting into the case. The first two groups didn't talk much about their own team stuff either.
No.
Yeah, they did.
Yeah, but I'm
That was a
wondering-
weakness.
I don't know if they understand that.
Yeah, I don't know, last year the teams did
They
it more,
did.
but the last two teams did
Did.
do that,
Mhm.
so I thought that was a weakness for first team, a little bit the second.